Greetings and welcome to the second part of a three-part webinar series on crafting richer public health messages, gaining broad policy support in politically polarized times. Brought to you by the Network for Public Health Law, the Center for Public Health Law Research at Temple University, and the American Society of Law, Medicine, and Ethics. Today's webinar will focus on messaging and the 5 essential public health law services. My name is Dave Clark. I'll be your host for today's event. Now, before we get started, there are just a couple of things I'd like you to know about. Concerning the audio, today's webinar is listen only. That means that you can hear us, but we can't hear you. But that doesn't mean that today's event won't be interactive. We will have a Q&A session at the end of the webinar, and you can type your questions at any time into the Q&A panel. The Q&A panel can be found on the right side of your screen. It can be toggled on and off by clicking the Q&A icon that you'll see on the top right of your screen, or if you're on a Mac today, you'll probably see that icon on the bottom right of your screen. Now, in the Q&A panel, this is very important. Make sure that all panelists is selected from the drop-down menu. If it doesn't say all panelists, please make sure to choose that option so that your question gets sent to the right place. And by the way, you can also use the Q&A panel to communicate with me if you're having any technical problems, including audio issues. Just let me know what the problem is, and I'll help you out. Again, make sure that all panelists is selected from the drop-down menu. We're really interested today in your thoughts and your questions and your comments and your feedback on this topic, so be sure to get all of that into the Q&A panel, and we'll try to answer as many of your questions today as we can, I promise. All right, well, let's get started with today's presentation on the 5 essential public health law services. Our moderator today is Jean Matthews, Director of the Southeastern Regional Center of the Network for Public Health Law. Jean is a senior investigator for the North Carolina Institute for Public Health at the Gillings School of Global Public Health at the University of North Carolina in Chapel Hill, where he teaches courses on leadership in health law and ethics for the UNC Executive Doctoral Program. Jean also served for 25 years as the Chief Legal Advisor for the Centers for Disease Control in Atlanta. As our moderator, Jean will be leading us through the rest of today's webinar. So, Jean, over to you.
Okay, Dave, thank you very much. I appreciate this opportunity. I also presented on the October 26th first webinar where we were discussing gaps in our current public health messaging and introduced moral foundations theory framework as one approach for addressing broader audiences. Also, my colleague today, Scott Burris, touched on a systems approach using the 5 essential public health law services model, which we're going to discuss in more detail today. We're becoming much more aware now of, how to go about this business, this messaging. If we want to help bend the arc of the moral universe more towards justice, then we in public health frequently need to change a law, a regulation, a policy, or get an appropriation shifted. And that leads us to advocacy and messaging. So we're becoming more aware of sort of 2 things: the need to be more connected through an interdisciplinary approach to advocacy, combining researchers, communicators, lawyers, advocates, evaluators, etc. And we're starting to develop more systematic approaches to target our limited resources and time on advocacy to do the most good. So today we have a very interesting and distinguished panel. Scott Burris, who some of you met on the previous webinar. He is with the Temple University, directs the Center for Public Health Law Research, which is also co-sponsoring this. We have Ben Winig, who is Vice President at ChangeLab Solutions in Oakland, California, and Doug Blanke, our colleague for many years with the Network for Public Health Law. He's Executive Director of the Public Health Law Center at Mitchell-Hamlin School of Law in St. Paul, Minnesota. So what we're going to do today is try to delve just a little bit deeper. Let's see if I can get the slides to advance. I'm sorry. Okay, I'm with you now. So what we're going to do very quickly today is Scott will first go a little bit deeper into the 5 essential public health law services approach, and how we need to be more systematic in targeting what we're going to try to change. Then Ben Winig of ChangeLab will show how this approach applies to the preemption issue. We had a lot of questions on preemption in the first webinar, and hopefully we can address that in more detail. And just a heads up, Ben will also have an interactive question, 2 questions at the start of his presentation. Then Doug Blanke will present his team's experience in examining early child care sector and what we learned from that. And finally, Scott Burris will come back and close out with what we learned with respect to housing code enforcement and housing standards. So with that, I think I'm going to toss it on to Scott Burris, and you've got the ball, Scott.
Thank you very much. Well, hello, everybody. I'm delighted to be here and to continue this discussion that's so important at a time when it feels like it's very hard to win battles in public health, and so many of the people we're trying to help and the people that we want to collaborate with seem unwilling to talk to us. You know, it's ironic that we have this problem because, you know, we really have good news. You know, we're in the business of producing good ideas to help people live better lives. And if you can't sell that, you really have no business being in the business of advocacy. But nonetheless, as I say, we're having some problems. So over the last few years, a lot of unindicted co-conspirators have been getting together in rooms all across the country and on long phone calls trying to think about this and understand various aspects of the challenge and ways that we could do things better. And if you're interested in digging deeper into that, this slide will have resources that you can look into. But broadly speaking, the story goes something like this. And we're presenting that in this webinar series. So in these 3 webinars, we're covering, first of all, we covered how do you know, what are some strategies and techniques for talking to people differently, to make messages that speak more to people's guts, more to their instincts, and create more space for ultimately sitting down and having those reasoned conversations and sharing data and trying to understand each other's positions and then cooperate. The next webinar, which I think follows very naturally from the first, is also kind of warm and fuzzy, but in a very practical way. We are a tribal country now. The first question we seem to ask when anybody speaks is, which side are you on? And yet, as I say, we should all be on the side of better lives for Americans. We should all be on the side of making this a healthier and happier place to live. So how do we get there in a time of tribalism? The third webinar will be talking about the vital importance of thinking of advocacy in terms of empathy and relationships that we build and feelings that we share, and not arguments that we hit each other over the head with. Now, the third part, but second in order of webinarhood, what we're talking about today, is about how to make sure that we have all the, you might say, the advocacy infrastructure that we need to successfully bring forward public health norm change campaigns. And when I say infrastructure, what I mean is now what we're calling the 5 essential public health law services. So that model starts with what we've been talking about as a transdisciplinary approach to public health law, which means that we have been speaking in our circle here at the network and the Public Health Law Center and at CDC and Public Health Law Research about recognizing the many important functions that people do in public health law who aren't lawyers. and to create an understanding or a model of public health law that reflects that. So here you see our little graphic on this, and I say you can go back and read the whole article that I showed you before. But the basic idea is that we have on the left those functions that we think of as public health law practice, what we've always called public health law. But we want to add to that what we're calling legal epidemiology, the functions of research and evaluation and policy development that are absolutely crucial to being able to effectively use law for public health. Another way to think about that is this 5 essential public health law services framework, and I'm going to run through it in a way that will demonstrate, I hope, to all of you how important it is for everybody who's doing a public health law function, whether they're a lawyer or not, to be part of our game. And also how important it is that we think strategically and critically about our norm change campaigns, our law change campaigns, to make sure that we actually have all the pieces in place to succeed. You know, there is no magic bullet, no special sauce, no secret to successful advocacy. As we've pondered the problems that we face, we've thought more and more about doing the things we all know how to do better and more strategically, and that was the genesis of this framework. We asked ourselves, looking at successful legal campaigns, successful instances in which law has really changed things for public health, what were the elements that made for that success? And this picture shows those elements. It takes us logically from sort of the beginning of the process when we're trying to figure out what the problem is and how law might matter, to the end of the process when we're actually evaluating the law and helping to spread it. And in between, we're looking at all that legal work that goes into crafting a good legal instrument that's at the right jurisdictional level and that's constitutional and well-written and effective, building the political will, the whole politics, getting it passed, actually successfully implementing it, and then measuring it. But it's not really linear, and in fact, you'll see some other pictures of this framework later in the webinar that's depicted in another way. The key is the elements and making sure as we contemplate using law and as we evaluate our successes and failures, to make sure that we have these things in place. So let me run through them and give you a deeper sense of what each one means. So at the beginning of any use of law in public health, there's some kind of problem. And there are people, generally speaking, not lawyers, who are studying that problem, or people in communities who are experiencing that problem, there are lawyers and people in public health who are trying to understand what we might do about this problem, whether it's opioid overdose or automobile crashes or sedentary lifestyles. And at a certain point, people will, in this milieu, this group of people of all different kinds, turn to the law almost surely as one of the ways that we can do something. So when they've reached the point of saying, well, there's room for some kind of legal instrument here, you get to the second essential service, right? The expertise in designing legal solutions, and this is truly primarily the lawyer's work. We have to decide what is exactly the best way and the best jurisdictional level to, in the best legal form, to put that policy idea into. But even here, non-lawyers are going to play an important role, because one of your big calculations is this going to be an idea that can be enacted? You know, where can it be enacted? If we can't win at the city level, can we win at the state level? Can we win at the federal level? That's not a purely lawyer question. That requires other kinds of political experience and wisdom. And at some point, you have a good bill, and you're going to try and get it passed somewhere. At that point, we have the political process. And that, again, is something that lawyers are part of, but only part of. You know, and it starts with making sure that from the start, as you've thought about what a policy should be, you've engaged the communities and listened to the communities that are going to have to support you, that you've created a climate in which people want to participate, or you've participated in a process that's really equitable and open. But of course, also that it'd be nice to have that sophisticated lobbying arm, a strong communications piece. All those pieces have to be there. If you don't have those, you know, the passage of that law will be a matter of luck. Once you pass something, though, you have to implement it. And particularly in a lot of laws we see, and we'll talk about that today in the case of housing codes, you see a real problem with enforcement. So that even though you have a law that seems to be a good law in the books and it's been passed and it reflects the nature of the problem, it makes sense, without enforcement, you might as well not have made the effort. And enforcement is often quite difficult and often neglected in terms of technical assistance and support. Of course, we also have lots of instances in which we can get a law passed at a city and then some big industry comes and challenges it. And tries to either win by constitutional law or win by just the cost of litigation to get a city or a smaller jurisdiction to back off. We have to be prepared to defend those laws politically and legally. And finally, if we've done all that and we've actually put a law into work and we were actually enforcing it properly and it seems to be going forward, how is that going to matter to anybody else in the country unless we're showing that it actually works? How are we going to avoid wasting our time except by showing that it doesn't work? So evaluation is a crucial piece and a crucial public health law service that we have to engage scientific legal evaluators into doing. We also would like to track the spread of these laws through policy surveillance so that we can be able to say who still needs this law, how are we making progress in spreading this idea, how many people we're reaching, and to create the kind of data we need for more ambitious evaluation. So we can use this framework for a number of purposes that you'll see us reporting on today. One is that we can assess whether in a particular legal topic area, a particular campaign area, these services are actually in place. Because if there are gaps, if we haven't thought through making sure all of them are present, then the chances of success are going to be much lower. But at the same time, if we identify a gap, presumably we can try and fill it through working with our allies and funders. Further down the road, it's possible to use these measures like we've used the 10 essential public health services to begin to develop measures of the quality of services. And in fact, in the work that we're reporting on today, the Public Health Law Center's team developed a really interesting tool for measuring the degree to which we are building equity into norm change campaigns, which is absolutely crucial. And then finally, we can use this framework to teach public health stakeholders to be more strategic and more effective as they design and implement law reform campaigns. I happen to be in Europe now, where I've been working with the Association of Schools of Public Health in the European region to develop this training for all 53 countries where they're working. All in all, the goal is not to, as they say, pretend that we have a magic wand or a magic bullet, but just to focus on doing the things that are in our control as thoroughly and as well as possible, and making sure that we have covered all the bases we have to cover to succeed. So now I'm going to pass it on to Ben, and I'll be back later with some discussion of how we use this framework in looking at housing code enforcement.
Thanks so much, Scott. Hello, everybody. Given the political and legal landscape facing local jurisdictions today throughout the entire country, I'm especially excited to join everyone to talk about preemption, health equity, and the search for local solutions. As mentioned, I work at ChangeLab Solutions. We're a national nonprofit based in Oakland, California that creates innovative laws and policies to ensure everyday health for all. And they pay me big bucks to let you know that we do not enter into attorney-client relationships, and none of what I'm about to discuss today constitutes legal advice. So with that fun stuff, let's get into the really fun stuff. Today, I want to briefly recap what preemption is, identify some examples of how it works in action, and finally review some of the findings from our study on preemption through the 5 essential public health law services framework that Scott just discussed. We're going to do federalism and police power in 30 seconds or less. As I'm sure folks know, government authority in the United States is divided between federal, state, and local levels. The primary source of this authority is the U.S. Constitution, and under that wonderful document Supremacy Clause, federal law takes precedence over lower level laws. Now, with regards to state law and its relationship to local law, states can choose how much, if any, of their police power, remember that's their power to regulate certain behavior in entities to ensure people's health, safety, and general welfare, they have the power to determine how much of that police power they will share with local governments. And as I'm sure, since this is a national audience, folks know the degree to which local governments have this power varies greatly by state. So what is preemption? Well, at its core, preemption is when the law of a higher jurisdiction limits or even eliminates the power of a lower level of government to regulate a certain issue. And to get a sense of how you all relate to preemption, I'd like to ask two very brief survey questions. The first, when you think of preemption, do you think it is generally A, good, B, bad, or C, neutral? You'll see the survey there on the right. You need to choose a letter and then click submit so the survey can close. So once again, when you consider preemption, do you think it is generally good, bad, or neutral? Once you choose it, please click submit, and we'll close the survey in 5, 4, 3, 2, 1. And it takes a little bit of time to have those survey results tabulated. And so I just want folks to think about, in their own state, what type of preemption issues have come up, and have they generally been, again, good, bad, or perhaps neutral. The next question I want to ask you concerns health equity. And again, I want you to think about, when you've dealt with preemption in your own state, how do you think it affects health equity? And I'm going to talk about these survey results in a minute. So in the next question, again, when you consider health equity, do you think that preemption generally advances or inhibits health equity? Same issues or same instructions. You need to choose letter A if you believe preemption generally advances health equity, or letter B if you believe preemption generally inhibits health equity. And again, the survey will close in 5, 4, 3, 2, 1. Please make sure you push submit once you've chosen your answer, and we'll take a look at those results. We've seen, if you've been following the national media, many stories about preemption and its impacts on certain communities and on equity, and I want to talk about that in our next slide once these survey results pop up. So we have a third of folks believing it generally advances health equity, and 2/3 of folks saying it generally inhibits health equity. Well, it's not surprising to me that the majority of folks think that preemption generally inhibits health equity, again, about 2/3 of people. And we had a little over half people think it's neutral, which is an accurate statement when you're considering it from a purely legal doctrine standpoint, and a little less than a third people thinking it was generally a bad thing. So I'm going to posit that preemption is not an inherently positive or negative tool. It's simply a legal doctrine, as I've discussed, that is applied to regulate behavior. But it is very true and accurate that with respect to public health and the social determinants of health, preemption has often been used to thwart the types of local innovations that many of us care deeply about. The history of the tobacco control movement is probably the best example of that. But a key learning from our project around the 5 essential public health law services is that preemption actually doesn't have consistent effects on health equity. And therefore, we argue that it is important to frame any policy intervention or social norm change campaign, as Scott mentioned, around the advancement of health equity, and then to assess how preemption might factor into accomplishing that goal. So let's take housing, for example. For those that live in California, you may know that the state legislature recently passed a preemptive law that strips local government's authority from regulating and ultimately denying certain multi-unit housing developments. The state did this to ensure that local governments no longer avoided responsibility for a severe and worsening housing crisis. Now, although this bill most definitely limited the powers of cities and counties in California, and certainly my city attorney friends were not happy with it, I would argue that it will most definitely advance health equity and that more affordable units will be built in the places that need them. But let's look at some other preemptive bills in the housing context. Kansas, for example, recently passed legislation prohibiting communities from requiring proactive rental inspection and from enacting inclusionary zoning laws. Texas now prohibits local laws that protect individuals from housing discrimination based on an individual source of income, like Section 8 vouchers. I think many of us, including myself, would argue that these bills and others like them, and more are coming in the next legislative session in 2018, are disastrous for health equity. In the field of civil rights And in the field of labor, we have the same issue. Preemption is rearing its ugly head. Like the Civil Rights Act of 1964, the Fair Labor Standards Act set a floor beneath which states could not drop. That was a good thing. That was an advancing equity. But now we have states taking this one step further and are imposing what's called ceiling preemption, and sometimes it even seems to target specific populations rather than being based on genuine policy considerations about the proper level of government to regulate certain issues. In the field of civil rights, folks may know of HB 2, North Carolina's so-called bathroom bill. With regards to minimum wage, what we had in 2015 is a great example of what I just discussed. In Birmingham, Alabama, African Americans make up approximately 75% of the population there. That city enacted an ordinance raising the minimum wage. Immediately thereafter, the Alabama state legislature passed a bill invalidating that minimum wage ordinance, and not only did that, but they prohibited local governments around the state from enacting any requirements relating to employee wages, benefits, and work schedules. Now, that state law was put into place without a single vote in favor from African American state legislators. In short, what I'm trying to show with these examples is this very real issue that preemption has significant consequences on both health and equity. It's not always negative, but it most often is, certainly in our world, and certainly more often or more recently, as we've seen. So how significant are these consequences? Well, that's a great question I just asked myself, and it's not totally clear. But earlier this month, there was an editorial in the American Journal of Public Health that caught the eye of one of my colleagues. In it, the author looks at recent mortality trends and hypothesizes, keyword there, I'm not arguing for or against his position, but I do find it to be an interesting one, that preemption has played a role in these negative mortality trends. In his editorial, he compares two states, New York and Mississippi, and he notes that in 1980, life expectancy differed by 1.6 years. By 2014, the difference was 5.5 years. According to the author, when it comes to life expectancy, New York now resembles Denmark and Mississippi resembles Romania. Why? Well, his hypothesis, 3 macro-level initiatives launched around 1980, deregulation, devolution, and, wait for it, preemption. He argues that these 3 initiatives have likely had far-reaching and yet underappreciated and unintended consequences for population health. With regards to preemption specifically, he notes that New York has not preempted local governments from implementing a variety of health-promoting legislation, as you see on the slide there, paid sick days, minimum wage, stricter firearm regulations, and calorie counts. In sharp contrast, he notes Mississippi has preempted local laws in these 4 areas. Now, regardless of what you think of his hypothesis, I would argue, and I believe others in the field would agree, that in some circles, particularly now, preemption is becoming the tool of choice among state legislatures to strip local jurisdictions of their power to innovate, of their power to create laws that improve health outcomes and advance health equity. So what to do? Well, this brings us back to the 5 essential public health law services. Here's another image of this that Scott mentioned you would see. Our work around preemption had 4 main findings, all of which have significant impact on messaging. First, to reiterate what I mentioned earlier, it's important to always frame preemption in light of how it advances or hinders health equity, rather than as a complex legal concept that isn't inherently positive or negative. In the development of tools and resources and in the provision of technical assistance, the field needs to ensure that campaigns facing potential or actual preemption are viewing it through this health equity lens. Second, capacity building. We heard about that already as well. It's an urgent need, particularly when it comes to designing legal solutions and enforcing and defending those solutions, 2 of those 5 public health law services. This requires funding. This requires organizational development to support municipal attorneys who are really fighting preemption on the front lines. Kim Haddow of the Rockefeller Family Fund has developed what's called the Local Solutions Support Center that is actively working on building this capacity and providing technical assistance for those who need it. Third, coordination across substantive issues working to combat preemption. This coordination must be enhanced. The current siloed nature of this work, we have plastic bag people over here, GMO labeling people over here, fracking people there, minimum wage people here, is truly hindering advocates' ability to effectively address preemption when it arises. I skipped a slide there by mistake. And finally, research is needed to further develop our understanding of preemption, to spread its awareness of how it's evolving as a tactic. We have this new type of preemption out there that people are calling punitive preemption or preemption plus, which is taking preemption to a whole new level. And messaging is a key component of this. Again, those of us working in this field are figuring out this messaging. Kim Haddo is another person who's working on this. So here's my bottom line. In the world that I work in and with local and state governments throughout the country, cities and counties must remain places of innovation where local governments, and importantly, the people they represent, have the power to pass their own laws to affect positive change, to improve health outcomes, and to advance health equity. I firmly believe that. I also want to share a note of caution and remember that many of the mechanisms that we now rely on for local innovation are actually vestiges of strategies that was once used to combat Reconstruction and civil rights. In other words, local control isn't always and hasn't always been a force for good. And I think we need to keep that in mind as an important part of the messaging that can't get lost in this current war around preemption. With that, I want to thank you for listening. I look forward to the Q&A, and I'm going to pass it now to Doug Blanke, who's going to discuss improving quality in family child care settings. Doug, over to you.
In Minnesota, where 20 attorneys and a dozen grad students work to create communities where everyone has a fair chance at a healthy life and no one is left behind. As you've heard so far today, we were part of the three-part project to pilot test what we are describing as the 5 essential public health law services approach. For today's purposes, the details of that process are probably less important than the basic underlying idea, which is that if we're serious about protecting health in these difficult times, we are going to have to adopt a more systematic and intentional approach to changing policies. The 5 essential law services framework is a way to do that. In this project, the Robert Wood Johnson Foundation asked us to pilot test the framework by applying it to 3 very different areas, which were not necessarily related to one another, to see if this approach has general utility to assess the state of affairs in any subject area and to gain insights for improvement. As you've heard, part of our group looked into the cross-cutting issue of preemption. And as you'll hear in a few minutes, others looked into the enforcement of housing codes. Our topic was the improvement of child care services. We used the 5 services framework to assess the services in place today to improve the quality of child care. We developed some key recommendations for a better process. I want to add that I didn't do this research myself. I'm not a child care expert, but today I'm going to do my best to channel our staff experts and what they have taught me. And first, I just want to acknowledge that this is a webinar series on the way we craft our policy messages. You might ask yourself what our analysis of the process for child care policy has to do with messaging. Well, our work convinced us, and I hope you will agree, that the need for better messaging goes hand in hand with the need for a more systemic approach to policy change overall. The two are inextricably bound together. In fact, some of the most fundamental things we learned were about the way we frame both our work and our message, and that the words we use and the way we use them can determine whether we succeed or fail. What was the issue that we're addressing? Well, 60% of the young children in the country today will spend part of this week in organized childcare of some sort. The experiences that they have there can set their course for life and help define the way they will feel about themselves, how they relate to others, how they learn, how they eat, how they play, and 100 other things that will affect their health for a lifetime. And beyond that, the child care providers turn out to be a key link between children and their community. For underserved populations in particular, we came to think of child care providers as first responders and a critical ground-level connection to parents and the community at large. So it would be hard to think of a better place to concentrate our efforts. We focused on that part of child care that is known as family child care. Family child care refers to the type of care that takes place in someone's home under systems of licensing and regulation that vary greatly from state to state. It occupies a middle ground, you might say. On one hand, it's typically smaller and less structured than child care centers, which receive most of the attention when people are designing regulatory approaches. On the other hand, family child care is also distinct from the informal type of care, commonly called family, friends, and neighbor care, that takes place in the home of the child or the provider and is largely unregulated. So we were looking at the middle category, which frankly has been neglected. From the inception, it was evident to us just how much the words matter. For starters, there isn't even an accepted definition of what family child care is. In fact, every state defines different categories of facilities and services, and these definitions overlap and conflict from one state to another. Nor, when states develop quality standards, is there any consensus about what quality even means. Is it about the quality of the relationship between the child and the provider? Is it about teaching the child so she will be ready for school? Is it about something else? There was no consensus. What were we trying to determine? At the risk of oversimplifying our 58-page report, we used the 5 services approach to assess the resources, organizations, and mechanisms that together help define child care quality, that set the standards, that measure how we're doing, and that help us do better. I would say we were looking at the system for quality improvement, except we didn't find anything we could truly call a system. So we set out to identify the most fundamental issues that complicate the process and make progress difficult. We determined who the key players were, what roles they play, how it's working, how the parts fit together or don't, where the gaps were, and what was missing for a more coherent and effective policy change process. How did we go about our assessment? Using the 5 services framework, we conducted a literature search, did baseline legal research, we identified the key organizational stakeholders, reviewed their services and materials, and then we matched them against the 5 types of services that go into policy change. We interviewed key informants, and we drew on all of this to map out the policy landscape and players and assess how they fit together. All of that enabled us to identify what we felt were fundamental gaps and problems and starting points for improvement. One of our most critical learnings came very early on as we concluded that everything we were doing had to be reframed to approach every question through an equity lens. So we ended up adapting the framework to ensure that we would do that. We ended up creating a 10-page guide or template, sort of an add-on to the framework, with a whole set of questions to ask to guide our thought process at every step to make sure that we kept equity uppermost in our minds. And what did we find? If I had to label one conclusion as our main finding, it would be that we think we need to reimagine what quality means for child care. Quality is more than the prevailing idea today that it's all about school readiness. Nor do we think it's about the array of services at a large, shiny facility with an extensive staff and specialization and corporate support. Those kinds of indicators are the things that have led us to a widespread assumption today that family child care is inherently inferior to the care in a larger center. The quintessential example of this entrenched conception is the widespread notion that a good measure of child care quality is whether the provider has a formal advanced educational degree, something that is not always present in the small home-based family care setting. But let's look again, and let's look a little more closely. While this is, of course, a generalization, our conclusion was that in these smaller family care settings, you have some other things. In the smaller setting, you have closer relationships between the provider and the children. You have definitely a closer relationship to the community. This was especially true in disadvantaged and marginalized populations. You are more likely to have cultural competence specific to those populations. You're more likely to have the language skills for kids who are learning English as a second language. You're more likely to have flexibility in the hours of operation and the unconventional hours that are barriers to access for so many parents. The service is often more likely to be affordable. These are assets, and so from this perspective, this is quality. That's why we concluded that it's time to rethink what quality even means. Now, two aspects of this were particularly important. First, we think we need to be much more holistic about the well-being of the child. It's not just about formal instruction. It's about every aspect of the child's well-being, from developing relationships of trust to addressing adverse childhood experiences, to hunger, to play, to sleep, to resilience, and on and on and on. Second, we concluded that the voice that most needs to be raised up and amplified in these conversations is the voice of the family care provider. Not only do they have the advantages I have already named, but on top of their connections to the child and the parents, we need to recognize that these are small business owners, entrepreneurs tied directly, immediately to their communities. From these perspectives, to a large extent, you could say that the success of these providers becomes the success of the child, and that becomes the success of the community. What else did we find? Well, we found that thinking focused on the model of a child care center, very formal, organized, and structured, has become the focus of the research that is going on in this field, and it's the paradigm for standards when they are set. But that these outcomes are then applied cookie cutter style to family care settings where they don't really apply and where one size doesn't fit all. Second, we found that regulation can be breathtakingly complex. I know we ended up seriously confused by some of what we found, and while that may not be the biggest problem confronting a provider if you're part of a national chain with a team of lawyers and compliance officers at your national headquarters, it can be paralyzing for a home-based provider who is simultaneously trying to prepare a healthy lunch that'll meet the state's food safety and healthy eating standards, but you're trying to fix the broken air conditioner, you're trying to understand the new fire code regulations, and one of the toddlers in the corner just threw up. You've got to supervise your staff and pay the bills, and oh yeah, you're trying to provide quality care to the children. This complexity is compounded by the fact that everything is so fragmented and disconnected, where we don't even have a standard vocabulary or definitions, so that we're using different words and definitions, and it's very difficult even to measure what's happening or to study it and make comparisons across jurisdictions. Given all of this, you can see why our first recommendation was for a process to bring together the right stakeholders, expertise, and resources for a coordinated effort to tailor quality standards for this environment specifically. Hopefully these standards would consider some of the things that I've said already about reimagining quality and would be grounded, even begin with, the perspective of the providers themselves. Just as with the lessons that we're learning about messaging and that were described in the prior webinar in this series, we believe that progress has to begin by seeing the problem through the eyes of those who are most directly affected, or even better, by giving them a leading voice in setting the agenda and defining success. Our second recommendation has to do with professional development and training. We found that care providers are hungry for support that will allow for better professional development. They often face crippling obstacles to achieving that goal. If you have a staff of 3, how do you send them off to training? Who pays for the training itself? And more importantly, who pays for their time while they're being trained? Who provides the care while they're gone? There is a critical need for opportunities that help providers overcome these obstacles. Even more fundamental is the underlying economic reality that regardless of the training opportunities available, without fair compensation, it will be very difficult for providers to attract and retain talented staff. Of course, this implicates much larger questions in society in general about wage fairness, minimum wage, tax policy, subsidies for child care, and income inequality generally. But there's just no ignoring these hard realities. Finally, along with professional development, we felt that part of what's missing is a concerted effort to reshape public perception of providers and to raise them up in a way that increases appreciation for the vital role that they all play. We also found, as I've said, that the system today is fragmented and disconnected, with people in various silos looking only at their own jurisdictions. We need a front-to-back interconnected system of support for quality improvement, covering all the different phases described in the 5 services framework. 2 key components are, first of all, a targeted national research program with an effort to identify the highest priority research needs, funding to accomplish that research, and a process to harmonize the inconsistent state definitions and categories so that the research can make comparisons across state lines. Second, there needs to be a serious program for technical assistance on policymaking and best practices with expertise in law and policy, as well as education and child development. This TA needs to be both wide and deep. What I mean by that is that it needs to be national in scope to draw on best practices and experiences coast to coast, but it also needs to be jurisdiction specific because of the way the regulatory systems are so distinct in each state. What does all of this have to do with crafting richer, more compelling messages? After all, this whole webinar series is about doing a better job of persuasion and advocacy. I think we all recognize that we're simply not communicating as effectively as we need to. Too much of what public health is saying today is just talking past our audiences. As public health professionals, I would be willing to bet that a lot of us look at an illustration like this and we see ourselves as the guy on the left, kind of the voice of truth and reason, offering what we would call evidence-based and therefore irrefutable arguments for our proposals. This guy's got charts and statistics. Heck, he's even got leather patches on his elbows. He must be a professor. And who's that other guy? He's obviously a hot-headed know-nothing who's so irrational and enraged he looks like he's about to throw a punch. But maybe there is another way to look at it. Maybe he's worked up because he's just tired of smug experts from out of town who won't put down their statistics long enough to understand his reality, the things that matter in his world, and the values that motivate him. A theme of all of these webinars is that too often that's what we end up doing. The people we need to reach aren't hearing us because we haven't listened to them. And while our pilot project on childcare was not about communications per se, there was a parallel, and this is more or less the same thing we found with a lot of family care providers. So to sum up, everything I've been saying probably comes down to the idea captured in the headline that's being used to describe the next and final webinar in this series, which is coming up on December 14th. In promoting that presentation, my colleagues are saying that they will be speaking about empathy and relationships as foundations for effective advocacy. We couldn't say it any better. That is exactly what we found in our child care project. The best foundation for progress, whether in communications or in policy change, is simple empathy and understanding that if we're lucky, and if we can work from a genuine relationship of trust and partnership with the people whose health and well-being are at stake, then maybe we can all pull in the same direction, get on with it, and change the law for better health. With that, I'm going to hand the microphone back to Scott Burris, who will talk about the third component of the pilot project. Scott?
Yeah, well, thanks, Doug. That was marvelous. Both the presentations were marvelous, and I almost couldn't pick up the microphone because I was busy trying to take off that blazer I wear with the leather patches. You know, I'm definitely the professor here, and in fact, I'm going to say some things about the importance of research and data that we discovered in our work, but it is not meant in any way to detract from what Doug has said. Because I think his summing up of this issue of how we speak to people and how we think about the way data helps us is really, really crucial to understanding better messaging. So we started with another equity problem. I mean, a problem that just in some sense exemplifies inequity. I think just the idea that 5.6 of houses that people live in this country, 1 in 5 are actually inadequate for living. It may be lead, it may be mold, it may be lack of actual sanitation materials, the toilets don't work, the water doesn't work, the heat doesn't work. 1 in 5. And it is not 1 in 5 evenly spread across the country, obviously. It's 1 in 5 of people who are poor in this country. So we start with 2 questions and 1 fact. In the work that we did. The fact is that housing code enforcement, although it has worked very well in many better off communities and helps us do many great things in nice condos and lovely suburbs, has failed poor renters for as long as anybody can remember. So our question was, why is that? And more importantly, if we think of this in terms of an advocacy 5 services analysis, what can public health and housing advocates do to improve code enforcement? Is there a movement to do that? Is that something that we've been trying as public health law advocates to do? Is that going on in the housing world or not? Our method was the same as Doug, so I won't go over it. We were trying to find out what people are saying in the world, on the web, and their publications, and people that we could talk to about this issue. So our main finding in terms of a systematic effort to improve housing code enforcement built on public health principles is that there hasn't been one. This has really been an orphan cause for decades. There are a lot of people who are concerned about lead, and housing codes comes into that. There's a lot of people who think about affordable housing, and housing codes come into that. But what we haven't seen, well, I should say there's a lot of people concerned about tenants' rights and work very hard for tenants in the courts, but there hasn't been, and housing codes are part of that, but there hasn't been a movement, a sustained effort to define, test, refine, and spread an efficient, effective model for codes and code enforcement. So as with childcare, and in some sense as with preemption, we've had a long-term problem that has been left to individual people in individual communities to fight out as best they could, small NGOs to struggle. They are definitely fighting hard, The question is, can we find a way to support them so that the fight can be smarter and more effective? In our analysis, we found that actually one of the crucial service gaps was essentially in that leather coated leather patch part of the world. For a very, very long time, we're talking 30 or 40 years, the conventional wisdom has grown that it's impossible to enforce housing codes for poor tenants without driving units out of the market and actually hurting tenants. This has been a force in the strategies and practices and tactics of people working in housing, and this belief is widespread in the literature, and it's widespread with everyone we talked to when we were doing our interviews. Yet, as Matthew Desmond has said, Desmond being the author of Evicted and sort of the leading light on researching what's really going on in housing for poor people today, this is a debate without evidence. In our report, we actually trace back to the one study, the one actual empirical study from the 70s from which this idea sprang, and show that really there's been no effort very, very few efforts to do anything about that since. And in fact, within a couple last few years, the Public Health Law Research Program of RWJF, that was out of which our center grew, actually funded some work in Rochester that showed that enforcement can actually be pro-poor, or at least neutral. And you don't have to drive landlords out of the business or drive tenants into homelessness in order to improve housing quality. So actually, what we defined as the important question going forward is not whether there are circumstances under which enforcing housing codes leads to loss of units and net harm to the poor. The actual question is whether it would be possible to devise an approach to enforcement that could protect tenants without a significant negative impact on the market within a broader effort to improve access to affordable housing. And we think that when you phrase it like that, the answer could well be yes, and it certainly can't be who cares. We should try and answer this question using the tools of public health and public health law. Now, there is a second important service gap that we identified in this area, and that has to do with and I think it's one that we see we would find in a lot of different areas of public health law, and that is that enforcement or regulatory activity is actually quite difficult. It takes training, it takes resources, it takes political support in a city to do good enforcement of any kind of law. And yet in the climate of budget cutting that we've seen across all our municipalities for the last 20 years, it hasn't just been public health, but also license and inspection departments that have also been cut. They've also faced increasing efforts to challenge enforcement on various constitutional or legal grounds that we talk about in our report. And although there are some groups that have paid some attention and tried to do some training, there's nothing like the level of support we need for improved models of housing code enforcement and improved training and capacity building for housing code enforcers that we would need to make a difference across the many poor communities in this country. So we don't have the quite same level of recommendation as the previous speaker, in that there's a good argument that maybe housing code enforcement shouldn't be a big issue that we turn into a movement. Well, the arguments for it, I think, are pretty compelling. One is that, as I say, there really isn't any evidence that we can't do effective pro-poor housing code enforcement. And it seems like, in some other work that we did, and we'd be happy to share down the road, that there is actually enormous scope to develop and test modern approaches to housing code enforcement, and some cities are doing that on their own. Finally, it's just morally repugnant, to put poor people in a position where they have to choose between homelessness or a dangerous home. That's just not right, and I don't think we have to fall to that level in this country today. Now, the counter argument, which I think is not terribly unreasonable, although I disagree with it ultimately, is that that code enforcement is better seen as a symptom of the deeper problems in our broken housing markets. We have huge swaths of housing in our country that may not be economically viable. They're in a process, they've passed the point of remediation in terms of economic efficiency. We have a shortage of affordable housing, but it's actually not clear whether that's because the rent is too high or the pay is too low. How do you solve that? We certainly need to be building more units, and we have a lot of poor people. So the argument here is that resources might be better invested in the sort of advocacy resources as well as economic resources might be better invested in efforts to spread things that we know work, like housing vouchers, and to continue to push the enforcement of fair housing laws in its broadest sense. Well, if yes is accepted, if funders and NGOs and advocates and people in housing decide this is worth a try, we think that the 5 services approach has suggested how you do that, that there needs to be a sustained investment that brings in all the stakeholders to devise and test and evaluate new approaches to enforcement that we think could work. For that, investment is the key. Now I'll turn it back to our hosts, our moderator, and we can turn to your questions.
Okay, thank you very much, Scott and Ben and Doug. Remind you again that we're able to take questions now for about the next 30 minutes. Use your WebEx Q&A function that Dave explained at the start, and I think you can find your way through it. We've already got questions coming in. Let me also remind you again that then the 3rd webinar will be taking place 2 weeks from today on lessons and examples for state and local advocacy. And let me just sort of also let you know that that will then be a lawyer-free zone. I will be moderating but not saying much because we really will have 3 top quality practitioners who will talk about using empathy and relationships in some practical success stories that have worked in the field. And I think you'll find Sue Lynn Ledford from Raleigh, North Carolina Health Department, as well as Gary Gunnerson on faith-based health, and Alicia Cole on the from a healthcare system, giving you some very practical information. So let's go to the questions now. And I think I want to start maybe, I guess I can start with Doug, but I think it also applies to Ben and Scott as well. Each of your presentations, whether it's child care or preemption or housing code, talks about building some sort of coordinating system or infrastructure that would work with this. Starting with Scott, starting with Doug. Doug, can you sort of talk about what that would look like in the child care area?
Thank you, Gene. Well, this is the kind of thing that we all recommended something that sounds very similar, but of course, something that was set up would be tailored to each particular field. What that would look like in the child care area would be worked out by the people who have devoted their careers to working in that field. But a model that I'm familiar with that I think is working very well and that I think might be a model for many of the other issue areas is the initiative of the American Heart Association, supported by the Robert Wood Johnson Foundation, that's called Voices for Healthy Kids. This is the initiative that focuses on children's health in the early years, trying to promote a healthy weight and, in general, the health of the child. It serves a coordinating function that mobilizes the resources of the American Heart Association, but more importantly is based on collaboration and coordination to build a movement in that direction and to look systematically at every aspect of policy change, setting a research agenda, evaluating policy options based on the research, trying to set a consensus agenda for priorities for policy change, and working to keep that agenda dynamic and evolving as the science evolves, and looking first to community coalitions so that it comes from the ground up, funding efforts by local community coalitions. So I think this is a model that might have much broader applicability, whether in childcare or in any number of other subject areas.
Okay. How about Ben? You want to talk a little bit? I mean, you had a broad span to deal with that preemption issue. How do you see a way through this, a coordinating system or a structure?
Yeah, sure. Thanks. It's a good question. I mentioned a newly formed entity, the Local Solution Support Center, which is a project that Kim Haddow of the Rockefeller Family Fund is just launching. The prior iteration was something called LEAP, the Legal Effort to Address Preemption, that is housed at Fordham Law School at the Urban Law Center. And that group has brought together legal scholars, advocates, and is really trying its best to break down those silos that I had mentioned among the various folks combating preemption, because what we have seen is an isolated win here, an isolated win there, but certainly losing the overall war, so to speak. And so that's the group that is now emerging to be this hub to this movement, and I think that's the place I would send folks. It's new and forming, and I think everyone in the field would agree with my comment that we're behind the 8 ball with preemption. We've been outgunned, outfunded for years, and now there's a time to kind of wake up and get going. But we're several years behind where we need to be.
Thank you. Scott, how about on housing code?
Well, I think our story is about the public health approach to problem solving. I think we have some good tools. We're good at collecting data about a problem, understanding it. We're often pretty good at talking and listening to and working with people who are experiencing the problem and understanding it from a human perspective, and engaging with people to find solutions. And then the important thing is that we, in the ideal world, we experiment, we innovate, we test, and evaluate, and learn, change, lather, rinse, repeat. So in housing code enforcement is an example of something that has been an evidence-free zone, as Desmond talked about, even as we have been aware, without any need for further research, of the extent of the problem. And really, I would have to call it a catastrophic failure of local regulation and local regulatory enforcement to protect people from horrific conditions. You just can't put too fine a point on it. And
yeah.
In this world, we have been doing things. We've been doing things legally. We have lots of. So we have a clear sense of the problem. We have lots of law. Housing codes are everywhere. They're voluminous. They're detailed. We have lead law at the federal level and state and local versions and so on. So we have all this law that makes it clear that you can't maintain a house in an unsafe condition. And we even have people working really hard to enforce that law. People who are dedicated and concerned in doing it, and yet the situation barely improves, or in some ways doesn't improve at all, and that goes on we measure that time in decades. That is the moment when, we have to say to ourselves, it's not a good idea to keep doing the thing we have been doing. It's a good idea to go back and see if we start over, bring everybody to the table who needs to be there, and in a properly supported and systematic way, see if we can beat this problem. Maybe we can do better. And again, in a small scale, it's being done. I've mentioned the Rochester experiment, some cities in Ohio. There are very places around the country that are trying to do something differently and better in strategic code enforcement. And we talked some about that in our reports. But that's what Doug talked about before at the beginning of his presentation applies here too, which is if we actually want to scale this up around the country and have what works be identified and spread to everybody, then we have to engage in a serious process that is aimed at doing that. Otherwise, it'll just be a series of, a few people will be better off in one city for a while, but 10 years from now, we'll still be in the same position.
Okay, I want to go to Doug next on ratios, but before I do that, Scott, while you're on the line, one of our listeners would ask, sort of what the last thing you said, are there some examples of current local law that's been adopted to improve housing equity? Anything in particular that comes to mind? You mentioned one or two, I believe.
Well, housing equity more broadly involves the issue of breaking up concentrations of racial and economic segregation. So inclusionary zoning is a part of that. The low-income housing tax credit can be a part of that if the money is used to build facilities outside of areas of concentrated poverty. The voucher, the HUD voucher program, Section 8 vouchers, the moving to opportunity idea can be a part of that if we actually fund more than 5 or 10% of the people in the community who actually qualify. So we have some things that we actually know work, and in some of those areas, it's more a question of proper funding than it is about not knowing what to do. That's sort of a different question.
Yeah.
If we talk about housing code enforcement itself, I would again point to the work that Rochester has done, and there's some research in the literature that you can look to that talks about how that's been done in the proactive code enforcement process. And hopefully our report will be out soon, and people can see some other examples there.
Okay. Let me go back to Doug then. A related question on your presentation. The question is, for municipality level child care improvement enforcement, how would you approach provider ratios? It's a common problem for home-based child care and was a barrier for local policy when this local health department tried to pass something.
Well, first of all, I will just say that our project didn't focus on municipal child care regulation, but this is part of the complexity that I was referring to. In most states, this is something that takes place at the state level, and in some states there is no preemption, and we have regulation at both the state and municipal level. Obviously, the child care ratios that are required by the public standards have a lot to do with the affordability and access and drive the determination of the cost of the care. I'm not expert enough to say much more about what those ratios ought to be, but I would come back to our core point that those are exactly the kinds of questions that can only be answered in the right way if we have authentic input at the very beginning from the providers themselves and not just from those who run the large child care centers.
Okay. Ben, I had a great question. You first, and then maybe Scott brought up local tribalism, so he may have to bail you out. But the question, very simple question, can preemption help reduce local tribalism? What say ye, Ben?
Yeah, I saw that question come in. I think it depends on how we're defining local tribalism and ensuring that we're talking about state preemption over a local law. So can it help local tribalism? Certainly preemption can get people working together in a way that they haven't before. I think it depends on the issue. I think a lot of it depends on the messaging around preemption and whether we're talking and whether you're using preemption messaging as targeting a particular issue, let's say tobacco control, versus preemption writ large of taking away people's ability to participate in democracy, which is really what's happening. And what you're seeing on the pro-preemption side are folks using terms like liberty and freedom and ensuring that states have the authority to do that. And I would say the same type of language might be used at the local level to ensure that people are allowed to pass the law, have a say in what they want in their lives, have a say in their health specifically, and a lot of local legislators are figuring out exactly what to do about this, and I think that there is a chance that it could reduce local tribalism, but it's complicated. And one thing I find interesting about this is many state legislators, not all, but many came from local, city councils or school boards or whatnot. And at the time they're serving at the local level, they believe the local level is the right place to make a decision. And then as soon as they get to the state level, they change. And so it's really about power. So I'll leave it there. I know Scott introduced that term, so I'll give him a chance to weigh in as well. But go ahead, Scott.
Well, you've said a lot of the important things, Ben. I think we have to recognize that there's a perfect storm here because ideology, anti-government ideology, is an anti-regulatory ideology marries very nicely with the self-interest of potential targets of regulation who, for economic reasons, want to avoid it. And that means that there's a lot of money changing hands here in our legal system of campaign finance, which, over here in Europe, they might look at and say, that sure looks like bribery to me. But it's not, according to our Supreme Court, but it is damned effective. So, we've, as Ben said, in the preemption area, we've been fighting this from within our public health silos, one issue at a time, with pretty minimal support until recently, whereas there has been an extremely well-funded industry political campaign to cause preemption. So I don't think there's an easy solution to it because whether you call that tribalism or self-interest or the way democracy works in the land of citizens united, it's not going to. There's no way to talk our way out of it. I think the argument that we can and should make at the local level is the truth. Of the fact that although we disagree at the local level, we're generally able to talk it out with each other and work it out in a fairly civil way, and that's why local democracy is typically a good thing. And when we lose the right to do that, we are going to create a lot of resentment and frustration that it would be better not to create.
We've got a whole cluster of questions around immigration and the undocumented. And so maybe the best way to go to this is what messaging would you use to increase healthcare access, whether it be, housing or a code or general preemption? What would be the best way to increase healthcare access for the undocumented? This person focused on the needs of a child who can't concentrate on school because concerned that the parents would be deported. But it's a cross-cutting issue we all face. Somebody want to take that one? Pass it around.
Well, this is a question that kind of is. Oh, go ahead, Ben.
No, I was going to defer to you two, but I would say that in terms of preemption and undocumented populations, sanctuary cities, a term I'm sure most folks know of, is a hot topic in the preemption world because you have the federal government, arguing that those that are providing sanctuary to undocumented are running afoul of law and will be stripped of potential federal funding. And so this has been challenged in court somewhat successfully, but it is a new area of the law because it hasn't been challenged in this directive away, in this impassioned of a way from the federal government before. So I'll say that. It has nothing to do with access to health care, I realize, but there certainly is a preemption component to undocumented folks that are living in sanctuary cities.
Scott, go ahead.
Well, I was just, this sort of is a better question for the last webinar, I think, in some ways, because, but we should answer it. You sat through this one. The argument that tends to convince us people in public health, and I'll say us more liberal people typically in public health, is, it's so cruel and unfair to treat these people this way. We're going to cause a lot of harm. The second argument we'll often make is it's kind of stupid because it's going to cost us a lot. It's much more efficient and effective and the data will tell us that it's better to increase access to care and education and everything else. So we've got the things that feel really good to us. We don't want to harm anybody, and we want to, be rational and follow our data. Now, of course, the whole notion of the illegal alien, the whole argument that's been going on for now, the whole sort of framing campaign to turn people who cross borders into criminals, into lawbreakers who must pay the price for their lawbreaking, was a campaign aimed at a different moral reaction, the reaction of respect for authority. And if we want to speak to people who tend to react well to that, we have to use some of the other things they care about. So, of course, sanctity, and the sanctity of life. The fact that every one of these people is one of God's children and needs the health care just as much as anybody else. I think to talk about loyalty, the fact that many of these people, and this is sort of what's worked fairly well with the Dreamer portion, is these are people who've actually committed their lives to our country. They've signed up to be part of our community, and they've done good things for us. They've helped us. And we have to be, they've demonstrated their loyalty to us. We need to demonstrate our loyalty to them. So, framing it as an us moral kind of question about people who are within our community, those are the kind of things we would say is a sort of quick answer. I don't think I don't want to be glib, and I don't think it's easy because there's been this fight. But fundamentally, we win whenever people see undocumented people as members of our community, and we lose when people see them as lawbreakers.
Doug, you got anything you want to add?
Well, I'm not a communications expert, but one thing I do want to add is that just recently at the APHA conference, the American Heart Association released a new messaging guide for policy advocates, focused on how should we speak about issues connecting back to health equity. And I really commend that to people. I think they've posted it online. It's called Messaging Guide for Policy Advocates. And while I don't hold myself out as an expert on what their research found and what they recommend, one of the examples that they give that I think relates to this question is that while it might sound like a subtle difference, they say we need to get out of the habit when we talk about things like healthcare access for undocumented kids. We need to get out of the habit of focusing our statements on the at-risk population that we're talking about, that some people might have the instinct of defining as the other. And we need to say the same thing by talking about we need health care for all our kids, no matter where they come from, no matter who they are, no matter how they got here. It's about all kids and health care. So that's an example of kind of a more positive framing that doesn't start by calling attention to the group that might not be within the sort of the starting point, reference point for the person who's listening to you.
Okay. All right, let's take empathy and equity aside for a minute. We've talked about that. Would each of you pick a theme in your case that you would recommend for public health advocates to use to improve the messaging on preemption, housing, child care? Scott, you want to start on that with housing, aside from the equity and empathy issues that you just talked about?
Well, at this point, our kind of pre-message is that we can do a lot better here. You know, I go back to the idea that no mother, no father should have to choose between having a roof over the family's head and exposing the kids to mold and lead and other dangerous conditions. We have to commit to solving that solvable problem.
Okay, Ben, how about in the preemption area? Again, setting aside for the moment empathy and equity, what is the central message to improve our messaging on preemption? Home rule, local determination, what?
Well, I think neither of those terms, because no one knows what they mean. And I think that's part of the problem with preemption, and I don't mean to say that.
That's why we'll have a lawyer-free zone next week.
Yeah, exactly, to be snide. But I think when people hear the term preemption, automatically there is either confusion or they turn off. And so the terms that are floating around now about local solutions, local innovation, and I think the fact that people, you know, we heard this a lot during the healthcare debate, people should be able to make determinations for themselves when it comes to certain laws and policies that impact health. And the best place for them to do that is at the local level, where there is still some sense of representative democracy and some ability to sway elected officials in a way that I think is becoming less so at the state level, and we know the situation at the federal level. And so I think that is really the key, which is people should be able to have a say in these determinations that truly impact their lives. And if we don't, you know, if we strip local jurisdictions from the ability to make these decisions because of preemption, we're even further withering democracy, which I think will have significant long-term problems for citizen engagement.
Okay, Doug, your team spent a lot of time on equity and dealing with the empathy issue as well. But moving on to the next layer, specifically, was it the issue of spending more attention on home child care, where 50% of the child care takes place, as opposed to in more formalized settings, or what's the way to improve our messaging in that field?
I think one example I might offer, if our goal remained as was our primary conclusion here, that we really need to raise up the role of family care within the child care world. I think one way to approach that without being explicitly focused on equity would be to reframe it in terms that are relevant for every parent, and that has to do with the access to child care and its affordability. When, as many people may not realize, when child care today has become as expensive as college tuition, and therefore unaffordable for many, if not most, parents who have more than one child, I think we might think about framing our messaging in terms of increasing access and affordability by being more creative and imaginative in finding quality within these less formal, less structured family care settings, so that we can achieve both quality and access.
Okay. Well, the best question we got for the day, we will roll that over until the next webinar. It was, folks, how can we in the U.S. be optimistic today about policy change? So again, as shown on your screen, I encourage you to tune in 2 weeks from today, where you're going to have 3 really dynamic speakers talk about some lessons and examples that you can be optimistic about. These are North Carolina related, but if you can do this in North Carolina, folks, you can do this anywhere. So I think that's enough for today. I thank you for your participation. I will turn it back over to Dave to close this out. Thank you very much.
And thank you, Gene. Thank you as well to all of our speakers today for their insights into today's topic, Scott, Ben, and Doug. And thanks to everyone who submitted a question. If we didn't get a chance to answer yours, we did receive very many questions today. we will follow up with you via email if your question requires an answer. Now, today's webinar was recorded, and you'll be receiving an email with a link to access that recording when it's available, so check your inboxes for that. There's also a URL on your screen right now that you can visit to access the recording when it's ready. That email you'll receive will also include a link to a brief survey that we hope you'll take. We'd really like to know your thoughts concerning today's webinar and what topics you'd be interested in for future webinars. We really do read all of your comments and feedback, so please be sure to take a couple of moments to complete that survey. You'll also be receiving an email from ASLME with information about applying for CLE credit for today's webinar. And finally, a reminder that the third part of this three-part webinar series, Crafting Richer Public Health Messages, Lessons and Examples for State and Local Advocacy, will take place on December 14th. To learn more and to register, you can visit the webpage shown on your screen. That's networkforphl.org/webinars. Thanks so much for being with us today. That does conclude today's webinar. Have a great day.